presentation as the blind spot, engaging men in contraceptive programs. The reason being is that we always talk about contraceptive program for couples, contraceptive program for men and women, but basically men are the one who are normally ignored in all these programs. And most of the focus has been and still is on the women and adolescent girls. So as I mentioned that we talk about unmet need, we talk about contraceptive programs, service deliveries, but we are, although we want to, but we have not been able to sufficiently engage men. We can see that the male condoms and vasectomy, even after a lot of promotions, since 1994, the percentage of the contraceptive prevalence rate remains the same. It has not shifted above. So it remains the same, and I'll show some graphics later on. And again, another important thing for all of us to keep in mind is that when we calculate the unmet need for family planning, we are generally looking at the women need for family planning. Men are generally not included. Similarly, the other challenge in addition to these basics is that although sometimes we want to support men reproductive health, the contraceptive services, but due to stockouts or due to unavailability of the trained providers, for example, for vasectomy, things are not available, although it is required, or we want to provide those services, but these are not available in some settings. Then again, another reality is that when we talk about new methods for male contraceptives, which is again always a topic of discussion at different forums, it requires greater research and funding. So somebody was telling me that at least it needs from developing an idea to marketing the product, it takes around 15 to 20 years for any such product to be in the market after all the safety and ethics and other approvals. So you can imagine it takes a long time, and we have so little in the market for the men in the context of contraception. We also have been lacking the definition of what do we mean more broadly, not only contraception, but more broadly, what is the definition of men's sexual and reproductive health? So this is the definition I was able to find, and it is in line with the broader definition of sexual and reproductive health as per the ICPD in 1994. So let me read it for you. Good sexual and reproductive health for men is a state of complete physical, emotional, mental, and social well-being for men and boys in their in all matters relating to their sexual and reproductive health system. It is not merely absence of disease, dysfunction, or infirmity. Instead, necessitate a more comprehensive and respectful approach on male sexuality and sexual relationship. So, I mean, this is broadly the definition of men's sexual and reproductive health, which is not commonly known, but this is something I thought I'll share it with you. And men's reproductive health is important, and it is not only that it is important in the context that we want it, but it is enshrined in many of the SDGs explicitly or implicitly. So we can see on the screen that SDG 1, 2, 3, 4, 5, 8, 10, and 13 engages men. And one way or the other, it talks about reproductive health and well-being of men in one way or the other. So when we talk about men, it is definitely enshrined in the global commitments. It is already agreed by the governments that they will take proper focus on it and proper care to this aspect of a men's role and men's health. But unfortunately, more focus has been on women for all the right reasons, but this should be equally appreciated and focused. This is some of the guidelines developed by our department at Reproductive Health and Research. We developed the guideline on, I think some of you will be familiar on medical eligibility criteria for contraceptive use, selected practice recommendation, or the family planning global handbook for providers. Sorry. So these are produced, and the section on men health is definitely included, but that is only limited to condoms and vasectomy. And I'll show you what is the share of these two methods globally. We also produce a very important document, which is the WHO Laboratory Manual on Human Semen Analysis. It is one of the most popular, I would say, document being downloaded from the WHO website. Apologies. Now, if we look at the contraceptives global overview, we can see that 1.9 billion women of reproductive age in 2019, 1.1 billion have had need for family planning, 850 million are using contraception, 270 have unmet need. Now, as you can see, everything is focused on women. Men are not in the picture at all. So, as I've written down, that the only available methods are vasectomy and condoms and possibly withdrawal. And men method of contraception, the R&D, the research and development of new method has been ongoing for the past 50 years, and still there has been no new breakthrough. Although there are few methods which are still in the pipeline, but still it will take some years, maybe a decade or more, before a new method is in the market. There was a survey done that 30% of the men would be willing to use a new method if it is available. And men definitely would want the male method of the contraception account for 27% of the method mix, which is again condom and withdrawal, and I'll show in the next slide. This is just to let you know also, I think this is important, that when we add a new method, I'm here say taking example of the male method, if it is developed, it also increases the CPR, MCPR by 4 to 8%. So increases the choice and increases the availability of method if people are willing to use, and definitely leads to better CPR, which helps the government achieve their national goals and also global goals overall. This is the current contraceptive method mix that we have. As you can see on the screen, that the male contraceptive method is 21% of the total method mix globally, and male sterilization is only 2%. So this is what it is about male methods. Although withdrawal can be part of it, 5%, but basically, if we talk about the modern method, it is condoms and male sterilization. So very little percentage, despite a lot of efforts in promoting these two methods. Although male condoms are very popular, definitely across the globe, but male sterilization has been very low, and it is only limited. It is highly prevalent in only few countries. This is another view of method mix of contraceptive use across different. It is from DHS, so you can see basically the purpose of this slide is to show that how different methods are used. For example, the yellow one, this is the condoms. As you can see, male condoms. It is very high in the teenager, younger age group, and as the age progresses, the percentage of user become less. Similarly, if you look at the green one, which is the sterilization, it is very, very less, of course, in the earlier age group, and it becomes more and more as the age progresses. So you can see what is the trend among general age group regarding the male methods. So the research gaps are basically when we talk about pregnancy intention, the male or the men's role seems to be missing. In many cultures, including in Pakistan, it is considered that it is women's domain and men should not be engaged or involved. But it is very important to understand men's need in contraception in order to cater the services according to the needs at the subnational and national level. New methods, development, R&D, this is important, but this is again a big gap, huge gap, as I mentioned earlier on. There are a couple of methods in the pipeline, but it will take a number of years before they come in the market. There was one trial run by WHO. I remember 7, 8 years ago. It was stopped in the middle because there were some cases of depression by that injectable method used by men, like the DMPA-IM or DMPA sub-Q. So that kind of method was under development, but then it was abandoned and the trial was stopped. So still, we have to wait for a longer time before a method becomes available. But this is a real research gap and real demand from the field. Uh, and the other important thing which we have realized is that whenever a new method becomes available, like DMPS sub-Q, although it is for women, but when it becomes available, unless it is done properly through implementation research, it is not accepted by the countries or the communities, and it is not easy to scale them up. So whenever a new method becomes available, it is very important to take into account all these different aspects before introducing it into the market, because once people have rumors and misconceptions about it, it is very difficult to find place for a new method in the method mix, whether it is for women or for men. And so specifically here, I'm emphasizing for men. In summary, male reproductive health is important but a neglected issue. Once again, I would like to emphasize on that. Because men are not largely taken as a critical actor in the context of contraceptive use. If you look at FP 2020 and now it is called FP 2030, if you look at the broader vision and goal of this FP 2030, it was written that we have to increase access of 120 million more women to access new methods for contraception who need them. So men are again missing. So, I mean, this is very important that the role of men and the critical aspect of engaging men should be highlighted at all levels. Investing in men can support, like I mentioned earlier on, achievement of SDGs. And last but not the least, I think when we talk about contraception, I think there are other aspects of men's reproductive health that are also being ignored but are equally important, such as infertility or reproductive cancers. A lot of emphasis has been on women reproductive cancers, and I again say for all the right reasons. But at the same time, it is important to engage and focus on some of the challenges men face in the same age category that women have during the reproductive age. So with this, I would like to end my presentation and would like to thank all the participants for being there and for the organizers for giving me an opportunity to quickly share some of the thoughts in the context of men's and reproductive health and contraception. Thank you.
Thank you, Dr. Moazzam, for your insightful thought and this important topic, your experiences and that you share with us. So as you have to leave early, so I'll take the chance to ask two questions. One is from my side and one is from our audience side. So you have discussed about the type of contraceptive that the man can use. I mean, like you had discussed condoms and vasectomy, two main methods. And you showed that a picture or a figure of mixed method, and then you showed that condoms, the prevalence is 21% and vasectomy is 2%. That is the global thing. So my question is that what challenges, I mean, this is the globally, this is very low, like, only 2% men are opting for the vasectomy. So what challenges you think that, you think that uh, uh, health provider face in counseling for these methods, especially for the vasectomy, when they counsel men for the family planning method?
Thank you very much. I think this is a important and interesting question because I was looking at the prevalence of vasectomy globally and where the countries, which countries it is being more accepted. To my surprise, it was in Maldives. I think it was Maldives, I think. Yeah. It is comparatively much higher than all the other countries. Uh, and there are a couple of countries in Eastern Europe where it is being used. But if we look at global picture, definitely it is very low. In Pakistan also, it is, I think, around 1% or even lower. I think it has to do something with the masculinity concept and the norms and associated with this masculinity, and definitely a lot of misconception that comes along with it. So I think the key challenge is how do we properly communicate and consult the clients when they come for these kind of services or they are obtaining information regarding these services. So what we are doing at the moment, and the other challenge we realize during this whole process in the past few years when we were reviewing this area, that counseling is an area in family planning that has been neglected for a long time. We have been looking at counseling with the hope that the interaction between client and provider happens in the best possible manner, but we have no idea how it happens. So what I'm doing at the moment is I am leading a research in Pakistan and also in Nigeria, where we are trying to develop a package of counseling where client and provider can have interactive, short but interactive and informative communication, where client is able to get the right information in more precise manner, what is required. So we are hoping with the understanding and development of this new package of family planning counseling, we will be able to communicate in a much better manner and more precise manner compared to the past, how we communicate with the clients in order to convince them to use a method if they are interested in it. Not coercive, but rather through voluntary, intention. So I think the masculinity, to come back to it, it is the masculinity in different cultures, how it is defined, and the concept along with it that it may cause more damage than benefit in case of vasectomy is something where we have to focus our counseling on. And I think with the help of more clear understanding, communication with the clients, it may support, it may help, but I think it's a larger issue of societal norms.
Thank you so much for a detailed answer and for this important question. So I have another question from the audience. So that is, I think you almost cover that thing, but if you like to add anything else, so you can. So the question is that what are the most common cultural barriers that prevent men from participating in contraception in the EM region?
I think, like I mentioned earlier on, it is not it's a sensitive topic in the Eastern Mediterranean region. Whether it is, we always thought abortion is something which is sensitive, but family planning is equally sensitive in our Eastern Mediterranean region. I think it is the initiative of the governments, the political will, how they present the case to the audience, to the communities. that actually makes a difference. If we take example of Bangladesh, although not in Eastern Mediterranean, but if we take the example there, the prevalence of contraception is very high because of the strong political commitment, and the commitment goes from one government to the next one. So they don't go back and forth. So once you have continuity in political commitment and willingness, I think these kind of programs work. And whether it is male or female method doesn't matter. It is the clear messaging coming from the top. So with clear messaging and also making them understand that there is more benefit than harm in using these methods. So I think this is where it is. Definitely, like I mentioned earlier on, the societal norms is another aspect that we, we need to look into. Thank you.
Thank you, Dr. Mozam, for your interesting talk and the way you answer our question. Thank you so much for joining us today.
Thank you.
Now we will move towards our second presenter. So I would like to invite Dr. Deena Badri. She is going to discuss about myths and misconception about family planning method among males and gender and socio-cultural norms influencing fertility. So floor is yours, Dr. Deena.
Hello, assalamu alaikum, and thank you very much for this invitation for this very important webinar. Greetings to all of you around the world. Yeah, my presentation, inshallah, will be focusing on gender norms and social norms influencing men's role in family planning. But first, I wanted to.
Sorry, Dr. Deena. Sorry to interrupt you. Can you please change your font to the sliding mode, your presentation, so we can see it clearly.
My presentation, Dr. Juwaria, she's. Did you find
on the
it?
slideshow? Can you move to the slideshow, Javeria?
Yes, ma'am. It's in the slideshow.
I can see it.
Okay, so maybe there's problem. Yeah, I can see it.
Okay.
Thank you so much.
Yes.
Sorry to disturb.
No problem. Yeah, so but you can hear me clearly, yeah?
Yes, it's very clear.
Okay,
Yes.
good. Okay, good. So yes, so if you can go to the next slide, I wanted to start by showing first the unmet needs for men, which I found in some of the studies in Africa. There's about a 24% unmet need for men. And this was in a study that was done in Kenya and Ghana. And of course, and then there was another study in the US where there was a 60% unmet need. And this was done about a few years ago. And looking at the unmet need of family planning amongst men is not very easily located or identifiable because obviously, for obvious reasons, the family planning unmet need is calculated much more for women, but really less for men. And this could be a reason which needs further research to look at the unmet need, which is like a beginning for why is family planning use or services for men very, very little in comparison to women. So starting with this unmet need, of course, is when many men don't, well, there's very little studies like has been shown. And the reason for the unmet need amongst men is the unavailability of contraceptives, their understanding of the importance of using family planning, the benefits of family planning, etc. And so therefore, the concept of men's unmet need in family planning is very limited amongst many parts of the world. And so therefore, I believe that this is a focus in itself that needs a lot of research and work to be done with different in different countries. The next slide shows the next slide, please. Next slide. Can you please go to the, okay, lovely. Here it shows in relation to the unmet need, it shows what choices do the men actually have. So obviously there's the known methods, which is the condoms and the vasectomy and withdrawal, abstinence and rhythm methods or the safe days. And this is the last three are actually like a cooperative contraceptive method between the male and female. As has been mentioned earlier, there's also the novel contraceptives, which include the gel, the injections, which are administered weekly, the male implant, and there's also, I can't see it from here, but there's also the pill. Some countries where these studies amongst men that were conducted, mainly in different parts in Europe, in Asia, and in India, and Latin America. There was a willingness amongst these men when their studies were done. Would you be willing to use the contraceptives? So there was a very high percentage of about 30 to 40% saying that yes, they would use the contraceptive, particularly the hormonal pill, which is administered on a daily basis. And they also showed a positive attitude towards the injections, which are administered on a weekly basis. The male implants still not, so these are all like trial studies, of course, and which have been done in the past years. And but the majority or the bright side of it, let's say, is that there was a willingness amongst these men who were tested and used as like on them to see if these pills actually, or these contraceptives, those particularly the hormonal ones I'm talking about, the novel ones, if they accepted, and the majority said they accepted, but still there was also a lot of side effects from using, for example, the pills. And it was similar, by the way, to the side effects that happen to women, like fatigue or loss of appetite or weight gain, sorry, or mood swings. So usually women, when they use contraceptives, they also, some of them, they have suffered some kind of side effect. So the same was happening also amongst men who use the contraceptives. But of course, there's a lot of debate about the hormonal contraceptives, in addition to the low funding and to for research or for the development of male contraceptives. There's also other issues like why should men use contraceptives? Why should we, which is the men, why should we use contraceptives? So there's the component of the masculine social, masculine norm in terms of this is a women's issue, but so this, and I think in conjunction with the production of these contraceptives, there should be some heavy counseling and sensitization amongst men that it is really not, the contraceptive is not really a male thing or a women thing, but it is for both, because it is at the end of the day, it is the health, the well-being and the good health of both the male and the female. So so there's a lot of debate and discussion about the production of these contraceptives, but in conclusion, those men who have undergone these trials, there was a positive response in these countries where the trials were taking place. Not 50%, but we're getting there. Next slide, please. These are just pictures of the male contraceptive pill, which are taken on a daily basis. And these are the injections, which are administered on a weekly basis. So I thought I'd just show you. It looks exactly like women's. And then, so like I said, the myths and the misconceptions amongst men, like I said earlier, that it is only for women, contraceptive. Most men believe that the contraceptive is only for women, and there's a masculine or manhood or machoism understanding related to it amongst the men. That it encourages promiscuous behaviors, it limits the family size, it may cause infertility for them or illnesses like cancers, and it reduces sexual pleasure, and of course, the vasectomies cause physical weakness or impotence. So these are all issues that, like I said earlier, need to be really talked about and discussed with the men and sensitize them that actually family planning or contraceptive use does not cause any of these concerns or worries that they have. On the contrary, it helps with their reproductive health, and it helps share contraceptive responsibility with their partners, which I'll be talking about also later. But it's important to point out these main myths that many men and many studies around the world believe that they share all of these in addition to other, maybe other reasons which are context specific. But these are the main reasons why men fear or understand about the use of contraceptives. And another thing to add is that this is not just about male family planning contraceptives, but also women's contraceptives. For example, some of men believe that contraceptive, if his wife uses contraceptives, then she will become infertile, or that he wants a large family, which I will also speak about because this all falls under the social norms. He wants a large family, so using contraceptive will limit family size. And this, of course, is in relation to the promiscuous behavior is also in relation to if his partner, wife, or spouse uses contraceptives, then it will lead to some kind of promiscuous behavior amongst women, which is all the myths, misconceptions, and misunderstandings amongst the men. So this is basically an understanding of how men feel about family planning. The next, yeah, thank you. The next one. Here we go into the gender and social norms. The next slide, please. Yes, of course, there's many studies about the issue of the family planning use with regards to gender and social culture norms from the perspective of men. For example, if you look at fertility, most men want to express their social status is very much expressed through having large families and taking care of large families, and expressing virility amongst the psychic of men is very important. Also upholding social religious values for increased fertility. For example, that marriage is primarily for procreation, having large families. Also, the importance of some preference for men is very important, and this is key in a key reason for the continuation of having children. For example, if a husband has 7 daughters, then he would still want to have a son. So that means having a total of 8 children. That's a very large family. But and also the continuation of the family name and extending their own clan. And also the influence on family side, the kin influence, either from his mother or her mother, or basically from the mother's side, more so from the father's side. So you hardly see a father-in-law. You might see father-in-law talking about why don't you have more children, but it's usually the mothers, either from the wife's side or the husband's side. So the concept of men wanting to have large families and therefore increasing fertility of a particular country and context is very much an important issue which needs to be taken into consideration with the understanding of why do men do not have all of these myths and misunderstandings about the benefits of family planning. And it is the understanding of fertility in their eyes, in their mind, in their psychic is counteracts the use of family planning actually the use of family planning and contraceptive, which takes me to my next topic, the next slide, which is the decision-making role of men in family planning. Not only because men are raised to be strong and to be obeyed and to be authoritarian or the main decision of family planning, decision maker for the family, sorry, and not only because they always want to be superior in the way they behave in their communities. And this is all, of course, this patriarch is all a socialization of how they were social or raised to the community, but also since he is also the provider and responsible for the decisions of the family, these also outplay in the reluctance and towards family planning use, whether for themselves or for their wives, or partners. These issues also are very important when it comes to family planning use, whether for the wife or for the husband. And if you go to the next slide, please. So in order to encourage or engage men and to counteract, for example, these social norms of decision making or dominance in decision making, and the need or the view or want for large families and their role, their contribution in high fertility in different contexts and countries. And this calls for the importance of involving men in family planning and contraceptive use. First of all, it is improving men's contraceptive knowledge, and actually not just their knowledge, but the accuracy of the contraceptive knowledge. Because this is very important, not just to know that there are contraceptives for men and for women, but what providing accurate knowledge about this contraceptive, the benefits, how to use, how to access, where to access, etc., is very important. So the key word here is accuracy of contraceptive knowledge. And of course, men need to understand that they have also family planning choices, like I showed in earlier slides, and they have also family planning needs which need to be addressed. The idea of involving men will also contribute to reducing their dominance or antipathy, which is reluctance towards family planning use, and also the creating responsible fatherhood behaviors, example, supporting their spouses during antenatal or postnatal care. So the involvement of the men will also result in addressing this issue of social norms where men are dictating decision making behavior. Another thing is also that in general, the health-seeking behaviors of men is quite low. And so therefore, because they are, for example, they are raised to be strong and usually hide emotions of health-seeking in general. But also the involvement in men in family planning will promote this men's health-seeking behaviors. Because I've seen in a study before that men hardly go to health centers unless they're very sick, let alone to, of course, family planning centers. They always hide their illness. They don't see that their understanding is that they're strong and they don't need to go to the doctor and so on and so forth. And so therefore, the involvement in men will also tackle or bring into tackle this problem of the low men's health-seeking behavior, which are connected to each other. For the women, the importance of involving men. For example, women might be tired of using contraceptives. She's been using it for 10, 15, 20 years, and she said she's had enough. And so therefore, if men are more involved in family planning, and they feel that they want to use contraceptives or see that, this will give this woman the chance not to use contraceptives, because it's really a shared responsibility or the right for both of them to use contraceptives. And of course, some women might have can't use contraceptives for different health reasons. And so therefore, the men should step in and help in that. And like I said, he also reduces unwanted untimely pregnancies. And the last point is, I can't see it from here.
Space
What's
birth. Space
what's the
birth.
Okay, and space birth. Yeah, thank you so much. Yeah, and spacing births. If you go to the next slide, I will also speak about the sharing. And for the couples, you have like I said, the sharing of contraceptive responsibility with spouses, their partners. In some studies, I've seen that the sharing of the contraceptive responsibility, and one of the key components is the couples discuss. It creates cohesiveness in their relationship, and it reduces dominance from men, and obviously it improves the overall status, reproductive health status of men and women. So really involving men has many obviously good reasons for it, for the men by themselves, for the women, and for the couples. So I think all of this boils down to raising the awareness amongst men about the benefits of family planning, in order to enable us to create this involvement and strategy or behavior amongst men, actually. If we go to the next slide. So there have been interventions discussing men's involvement, like I've showed previously. And the main issues, or the main core issues discussed in this intervention, is talking about the patriarch, men's social position, and addressing women's role in her family planning decision and decision-making power. So these are very important underlying socio-cultural norms, which the interventions have seen that they need to really talk about. So it's not really, for example, okay, men, these are the contraceptives, this is how to use it, this is where you can get it from, and these are the benefits of using, for example, contraceptives, either for yourself or for the women, your spouses or partners. But it's really it's really discussing the men's behaviors and how they view contraceptives and the importance of it. And I think from my work and my study and research, I think this is where we are at now, to talk about, to discuss, to sensitize, to engage men in this perspective. So we're still in stage one, I think, where men need to be told to discuss with them, to have like focus group discussions, small workshops, or to engage women and tell them, understand their social position, their upbringing, their socialization, to try and create a cohesiveness between men's and masculine behavior, because this is a really an important factor which creates a lot of negative energy and understanding against family planning use, whether they're for themselves or for their wife. So the discussion should be not only about men. If you're talking to men, you're not only talking to men about the benefits for yourself, for men, for the reproductive health of men, but also about women. So couple engagement is very important, even when talking to men alone or discussing about the benefits of family planning for you and for your wife. So if you're speaking to the men, you speak to them about, I think it would be beneficial to speak to them, about the benefits of family planning for both the men and the women. So the interventions also focus on supportive partnership between for men to be supportive partners for their wives or partners, agents of change, and clients and beneficiaries, which is encouraging men to use family planning services or male family planning methods. So if we go to the next slide, we'll see where these interventions are or the methodologies. Yes, like I said, most of the interventions used follow these techniques in their interventions to reach men and involve them. The production of education material, counseling and education, sensitization, training of health providers, and then this is at policy level, it's policy development in terms of having certain policies in ministerial level, for example, where it addresses the reproductive health of men, and networking between different organizations which are working for or creating interventions for men or working with men's health or men's reproductive health. So here it is all about education and training or sensitization. So this is more important. These are the most important methodologies these interventions have used, and I believe needs to be replicated and duplicated in future interventions. If we go to the next slide, it shows where some of these interventions. These are just examples of interventions. There's many more. So, for example, in Africa, we have one in Niger, which creates change agents amongst the men to sensitize other men for equitable relation and behavior. And this is here we're looking, you see here, we're looking at social norms or behaviors amongst men, how we can address that and how it can be how they can, it becomes more conducive for family planning use. And here in Congo, we're looking at educating couples for promoting gender equality and positive masculinities. Here also, we're talking about, in this intervention in Congo, we're talking about social cultural norms, for example, masculinities or social culture norms which impact masculine behaviors. If we go to the next slide, these are examples also from India and Bangladesh. In India, they have the Men in Maternity program, where they have where they're carrying out education for women and men and women's needs. And in Bangladesh, we have training of service providers in how to counsel their field workers to deliver male reproductive health services in rural areas. So all of these let's go to the next slide before I make my comment. If you go to the next slide, please, in Latin America. We have also, these are examples in Latin America. We have in Nicaragua, this is another intervention. And they are focusing on producing educational material, family planning for men, and creating workshops and focus group discussions with men on fatherhood to create responsible fatherhood behaviors. And in Brazil, we have, this is a more advanced intervention because they're creating a policy at ministerial level in order to create a department, or they have created a department for men's health. And this department is responsible for overlooking all the policies regarding to men's health, men's sexual health, men's reproductive health, and also the training of health workers to address men's reproductive health needs. And I think this is a good this example in Brazil, yani, is gives us hope that this could be maybe one day duplicated in other countries where there is a policy looking at men's health and focusing on their reproductive health needs, and also strengthening couple communication, like shown here in this example from Brazil. And then if we look at a global alliance, there's the Men Engage Alliance. This is a global network which brings together different organizations and NGOs which are addressing different issues in relation to men's involvement in family planning. And I believe this is the last slide. If we go to the next slide, yes. Thank you all for your kind attention, and I hope it was fruitful, and we look forward to a discussion altogether. Thank you very much.
Thank you, Dr. Dina, for your detailed information, your experiences on myths and misconception, and the examples you have given. So we have started getting the questions, but I'll take after our next presentation. So we'll take the question together. Thank you so much. So without wasting our time, I'll move towards our last presentation. And I would like to invite Dr. Syed Khurram Asmat to have his thoughts on gaps and challenges in male contraceptive uptake. So over to you, Dr. Khurram Asmat.
Thank you, Dr. Faria. Thank you, Dr. Javeria, and thank you, Dr. Sara Salim. Assalamu alaikum. Thank you to all. Before I start my presentation, I must thank my colleagues, esteemed colleagues, Dr. Dina and Dr. Mozam, to set up a very beautiful stage. They have provided some very informative knowledge on the male contraception, male SRH, use globally, their perspective, social norms. So my presentation will take you into the gaps and the challenges and the barriers, how those are being dealt, and then I also focus on the EMR region, including the global, giving you the global perspective. So I'll share my screen and run my slides. Just give me a second. Please confirm if the slides are visible to all.
Yes, sir.
Yes.
Okay. So as we all know, and as per my esteemed colleagues have already mentioned about the men and their role. So most men are not engaged in SRH care, the sexual and reproductive care, which includes the male contraception as well. We all know, and it has been shared earlier, that the current policies and programming are mostly woman-centric. Relatively few programs with men and boys go beyond the pilot stage or a short time frame. But despite the emphasis and importance on men's health in the definition of reproductive health, sexual health, that Dr. Mozam also shared earlier, relatively few results for men's health have been obtained from the extensive reproductive health agenda. Promoting appropriate couples interaction about reproductive health services facilitates informed decision making for spouses. So focusing on the marital context of the couples is essential to promote the quality of reproductive health services, and such as mutual interaction between policymakers, implementers, programmers, the propagandist of the reproductive health program includes religious leaders and social leaders, is the main factor in achieving better results in reproductive health and sexual programs. So these are the key barriers. The next few slides, I'll talk about some of the key barriers to the participation of men in the SRH, and this is global perspective, and later I'll move on to the Eastern Mediterranean region where Pakistan is also included. So the first one is the failure to access of all inclusive and integrated quality services. So the concept of male participation in policy making and management of SRH is lacking. As I've said earlier, that the policies are mostly women centric. In most part of the world, women are still the primary target of SRH services, and that's completely right. Uh, Political and conceptual barriers to SRH lead to men's deprivation of SRH services. Lack of communication between the policymakers, especially the people who are involved in SRH policy making, and the service recipient, like couples or the families, beneficiaries, causes SRH policy to be designed and implemented hierarchically, like it's like from top to bottom. So you're just designing things and you're implementing a thing what you see, but you don't go to the grassroots level and see what's the actual problem, and then you design the policies. The availability of SRH facilities and service environments, including programs, staff, equipment, and professional behaviors, are effective in the presence of men. So, if the men are available, men are present, so it creates an enabling environment. We'll talk about more later on. Male participation in reproductive health services encouraged. The status of healthcare facilities for men and couples has not changed, although unwelcoming attitude, non-acceptance of the presence of men, the presence of a male, embarrassing female staff, indifference of work, use of disrespectful language, mistreatment and misbehavior of healthcare providers towards women and their husbands reduce men's participation in healthcare. And this has all come out from several systematic reviews have done, and recently there is a systematic review of 58 programs in the countries which has given this exciting information. Then it's economic issue barrier, where economic status is one of the main structural determinants of perceived quality in the context of reproductive health. Clients' financial limitations are reported as an effective factor in the presence of men in reproductive health center. Men play the role of financial supplier of RH services for their families. So the high cost of care and the lack of sufficient resources may jeopardize men's role. Another important area is job responsibility, known as an obstacle to the presence of men in SRH, because based on the job timing and their away from the home, they mostly miss the appointments, or they don't go there. And again, this factor indirectly affects men's economic status as well. For men with little daily income, leaving the workplace to attend reproductive health care can put them in economic situation at a risk, and it can affect their decision to participate in reproductive health care of their families. Now, couples' personal preference and attitudes. Men's health-seeking behaviors are influenced by embarrassment, anxiety, distress, and fear caused by inadequate awareness about the services and medical culture. Prevalence of the patriarchal attitudes in male. Men's tendency to participate in RH care relates to their knowledge and attitudes towards reproductive health services. Sometime, or most of the time, shamefulness and reluctance were the main barriers to men's access to RH services, such as contraception. RH is institutionalized as women's health, so providing services in RH center is not favored by men. Males' unawareness and misperception regarding reproductive health and sexual health are common barriers in their participation in a reproductive health program. So, promoting men's presence in reproductive health services requires programs that focus on men's knowledge and attitudes through community-based health education. Of course, expanding the method mix for men, as what Dr. Mozam earlier mentioned, that there are other methods being piloted and tested, but we only have like two: condoms and vasectomy as modern method, and withdrawal as a traditional method. Poor interaction between couple is associated with the poor men's engagement in the reproductive health services. Although Dr. Deena talked about social culture and the norms, but I'll also take you there from the barrier to this participation of men in the RSH lunch. So one of the factors that discourage men from participating in reproductive health is the dominant traditional beliefs and gender roles that are culturally determined. Men's participation in reproductive health, including family planning program, investigation of sexually transmitted diseases, is mostly influenced by religious beliefs. Religious beliefs in reducing men's presence in the healthcare program is also identified as a key characteristics. For the social norm, the presence of men in RS center was unfamiliar and socially unacceptable. Males refuse to attend maternity and antenatal care due to fear of being seen by community members. So there is a there it goes on. Like we have seen, and I've seen in my 25 years of practice that males are reluctant to go inside, and they don't. Although most of the time they are not invited, but there is also not an initiative from the men as well due to the fear of being seen and discorded. Then. Males are also described having a crowded family as social credit. And here, social credit means if you have more children, you will have more finances, especially what happens with the lower income families in Pakistan and in developing countries. So they tend to have more children. It brings more social credit to the family. And stigma as a barrier, one of the main preventive factors for male participation in RH care is fear of stigma. Men were ridiculed or humiliated for being involved in maternal care, just like social norms. So these are barriers which somehow have become social norms, and they are actually not social norms. Fear of other men's reactions prevented them from participating in various aspects of reproductive health care. So if men participated in RH programs, they would be described in negative and derogatory terms, and it has been reported in certain studies and systematic reviews like they are under the control of a woman, waiting like a woman, dominated by a woman. So these are very common phrases, not just like in the developing countries. There is a precedence of them in the middle income or high income countries as well. So I'll take you to the Eastern Mediterranean region where Pakistan is also located, and I'll talk about these countries, especially the focus on barriers, gaps, and challenges. So this slide will is giving you the CPR unmet need of EMR countries, and you can see we have a high unmet need and a low CPR. I won't go into details. Unmet need for contraception in EMR. So many EMR countries have high rates of adolescents, pregnancies, and unmet need for contraception. Likewise, EMR, the Eastern Mediterranean region, has one of the lowest contraceptive uptake and second highest unmet need of FP globally for globally after Africa. So these are some of the specific barriers, gaps, so you can say challenges to SRH in our Eastern Mediterranean region. And I've talked most of them about it in the global perspective, but for the EMR region, fear of stigma, loss of social status, shame and embarrassment, unreliable, disrespectful healthcare providers, lack of privacy, confidentiality within health facilities, inaccessibility of appropriate information of counseling and medicine. And I remember Dr. Moza mentioned about the counseling package being revised for Pakistan, Nigeria. I'm part of that process in Pakistan. So later on we'll give you some good information once the studies are completed. In only 10 member states of EMR, there is a special component to meet the needs of male. Uh, it was found to be absent in Afghanistan, Egypt, Iraq, Jordan, Oman, Sudan, and Yemen. Uh, from the literature, we also found religious belief is another common denominator for EMR countries, just like global, and cultural views on family size may also vary, that sometimes plays a role for acceptance and use of contraception. So culture and religion has its own value and its own barriers and challenges for this reason. So in the EMR region, SRH is seen as a public health challenge due to high prevalence of HIV/AIDS, in addition to SRH program among people who inject drugs and men who have sex with men or among sex workers. Major gaps were described were inequalities in the access to SRH services and adequate education formation. So we don't have like a sexual health education as a formal part of our curriculum anywhere in school, university, of college. Not even like in medical university, we do talk about medical sciences, but the specific curriculum programs who are most effective, under what circumstances and levels they should be scaled up, whether at community level, through mass media, in a health and social setting, in schools, in military, and so on. What are their critical characteristics? In which cultural settings do they work? How much do they cost? And which are the most effective? So in a recent systematic review of 58 programs which focused on engaging men for SRH programs and contraceptive. There were like 58 programs, and 22 of them have group education. 8 programs were service delivery based, 7 were like based on community outreach, mobilization, and using mass media campaign. And 21 programs were integrated, like they include more than one approach. So we have seen only 17 programs out of the 58, or 29% programs were found effective. 22 programs or 38% of the program were promising, and 19 programs or 33% of the programs are unclear. So this is a systematic review. Have reviewed systematically and done meta-analysis, and have seen like which programs were effective, promising, and unclear while engaging men in SRH and contraceptive programming. In the well-evaluated programs, the changes were observed, like the programs are implemented, they were evaluated, and in those programs we have seen evidence of increased contraceptive use. We have seen increased communication with the spouse or partner about child health, contraception, and reproductive decision making. And one program which I would like to give as an example, because I don't have much time, so I'll just go an example of a program on male motivation campaign in Jordan called Happy Family, that increased contraceptive use. It increased communication with the spouse and partner about the child health, contraception, and reproductive health decision making. It has produced more equitable treatment for the children as well. So that's all from my end, and I have taken this information from these peer-reviewed papers and reports. All the information which I have provided to you is being cited in these papers, and you can get them if you like from the Department of Community Health Sciences, Aachen University. So thank you very much. So nice of you.
Thank you, Dr. Khurram, for your talk, for your discussion, and it was really interesting to listen about the challenges and then the program that have been running out for the communication. So we have got some question from the audience. So I don't have much time to cover all questions, but I'll take few questions. So because we are running out of time. So I have a question to both of you, Dr. Khurram, you and Dr. Deena, to both of you. So that there is a question that uh, that the females are already at the at the clinic and at the at the doctor's room for their gynecological problem, for the antenatal care and other things. So they said that in the countries, underdeveloped countries like Pakistan or like Sudan as well. So isn't it extra economic burden on the country to plan program for the counseling, for the for the family planning for the males? So they said that the female, what I understood, that female is already at the clinic, so you don't need extra effort, don't need extra economic things. But for the males, you need an extra effort, extra, seminars, program, and you need to spend more money on that. So the country like Pakistan and other underdeveloped countries, so isn't it extra economic burden on the government? So I would like to take answer first from Dr. Khurram and then from Dr. Deena.
Thank you, Dr. Faria. Very interesting question. Well, you have to see a larger picture. If you talk about the developing countries, see how poorly they are performing. Their contraceptive uptake is poor. Like in Pakistan, it's stagnant. For the last 3 DHS, we are seeing the almost same results. The at places like it's reported by one of the paper published by the Population Council in Pakistan. So they say that the slight increase is CPR, maybe because of the high use of abortion services. So we have to involve men. There has to be couple decision making. The last DHS have shown that couple decision making have slightly increased, but it's not enough. Especially in the rural Pakistan or the rural developing countries, they are one of the largest chunk of the population. Like in Pakistan, 60% of the population lives in rural countries. So how can you anticipate that the woman is making a decision. Although men are making those decision, but it's the woman. It's at the end of the receiving end. So couples, men need to be involved in decision making. Men need to be involved there at the health services, and they must see that. Of course, there are provider behaviors, there are healthcare worker behaviors that prevents them, and I've given you examples, the words, the remarks that has been reported globally, especially from the developing countries. But this is important because if you don't involve men, uh, you won't be able to make that change, because it's good to have women there, because most of the methods which are used in Pakistan are like hormonal for women, the reversible implants, the IUDs, irreversible female sterilization. So that's the reason woman is there all the time. But anyhow, the main involvement is very important for couple decision making. That's my perspective on that. Thank you.
Thank you, Dr. Khurram. Now I'll move to Dr. Deena. What is your stance on this question?
Yeah, I think it's also very important to involve men and to have this understanding amongst the healthcare providers that involving men and or involving them both as a couple is very important, because not only are you looking at the behavior or the role of men in women's contraceptive use, how they decide for them, or etc., but also when men are invited into the clinic, then you're actually targeting both the man and the female. If, for example, the wife is there to use a certain contraceptive, having the husband there and listening to the information provided by the health provider is also an enlightenment process for him, understanding what contraceptive his wife is using, and this will and how she uses it, etc. And this will reduce the resistance amongst the men. So really, having the men in the clinic with their wife during sessions should be focused, and providers should provide couples counseling sessions rather than women counseling sessions, or separately men counseling sessions. So it is not an extra financial burden. The provider is there, the clinic is there, the contraceptives are available. So if the wife wants to use, she comes to the clinic, and I think it is also the role of the health provider to emphasize and to stress that if you are coming, then please bring your husband, and there should be some kind of link or connection between the health center or the health provider and the husband in terms of engaging the men. So if he's there and listening to all of this information about the contraceptive his wife is using, right there and then you're having some kind of shared contraceptive responsibility. You're having some kind of cohesiveness in the contraceptive relationship, if you want to say that. And you're also increasing men's understanding about the contraceptive and engaging them. So couple counseling, I think, is not a financial burden, but an important aspect of allowing women to use and to continue using the contraceptive. So I don't think there's any financial burden in that. Another thing to add to that is also it is important that health providers need to understand how men behave, and well, many of the health providers usually shut the men out of if the wife comes in, then the men are not welcome to come in. And so therefore, the health providers themselves need to understand that the husband's presence or the man's presence during counseling session is just as important as their role in providing the contraceptive to the woman or to the wife. Thank you.
Thank you, Dr. Deena. Thank you, Dr. Khurram. It's really interesting. It's really, thought-provoking talk, and we discuss. It's really good. Thank you so much. And I also, strongly believe that couple counseling is really important, and we need that couple counseling. We can not only save the money, but we can save the time as well in the decision making. So now we are wrapping up our today's session, and today we have an enlightening and thought-provoking discussion Our panelists have truly provided us with a wealth of thoughts and perspective on men's take on family planning and contraception. So I want to thank our panelists for their valuable contribution. Your insight has shed much needed light on the challenges and importance of discussing this topic. Thank you so much again, and thank you so much for our audience participant, who attended this webinar. So thank you once again, and I hope you all have a wonderful evening. Thank you. Over to you, Javeria.
Thank you everyone for your active participation and engagement in today's webinar. Your presence and active participation are greatly appreciated. Throughout this session, we have covered a range of important topics. We explored how societal expectation, culture norms, and lack of education often keep men from being fully involved in contraceptive decisions. However, we have also learned that their engagement can lead to more balanced and informed choices in family planning. We discussed the need for open communication between partners, emphasizing that family planning should be a shared responsibility with both men and women contributing to decision about contraception. Our speakers highlighted the importance of advocating for policies and programs that promote male involvement in reproductive health. It is crucial that we challenge the traditional narratives that often exclude men from this conversation. We identified several resources and tools, from educational campaigns to community support systems, that can help empower men to take an active role in contraception and reproductive health, fostering a more collaborative approach. A special thanks to our esteemed speakers for their expertise, insights, and dedication to this cause. Your perspective had added tremendous value to today's discussion, helping us to better understand how we can drive change in this space. As we wrap up, I hope each of you leaves with a stronger commitment to advocating for male involvement in family planning and reproductive health. Together, we can help foster a culture where shared responsibility is the norm. Thank you again for your participation. Let's continue to work toward a future where men and women partner equally in these vital decisions. Have a great day ahead. Thank you, Allah Hafiz.
Thank you very much.
Thank you, Allah
Thank you.
Hafiz.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank
Thank you very
you.
much.
Allah
Thank you very
Hafiz.
much. Allah
Allah
Hafiz. Thank you.
Hafiz. Allah
Allah Hafiz.
Hafiz.
Thank you.
Allah Hafiz.